Okay, good evening once again. Well, I'll take this opportunity to welcome you to today's webinar. Our webinar today is on anesthesia and analgesia and cancer recurrence. We'll immediately start. So our speaker today is Dr. Ngugi, who is a lecturer at KU, Kenyatta University. He also has interest in pain and also education and research. So he'll be a speaker who will take us through the session. Our webinar today is hosted by KSA together in partnership with Novartis. So they'll also have something to offer to us. Without wasting any more time, I'd ask Dr. Ngugi to go ahead and start his presentation. Karibuni.
Good evening, everyone. My name is Dr. Ngugi Kigera from the Kenyatta University School of Medicine. I'm here today to speak about anesthesia techniques, anesthetic agents, and analgesia, and how the effect with cancer recurrence. We just look at where we are when it comes to this important topic. So I have no conflict of interest. I have no personal financial interest to declare. So looking at this topic today, we'll cycle through discussing what is so-called cancer tsunami. We'll also look at the overview of cancer recurrence and mechanisms of metastasis. We'll also delve a bit on how surgery affects cancer progression, and look at understand how different anesthetic agents may influence cancer recurrence and metastasis. So at the very beginning, we just want to understand how big is cancer. So globally speaking, we get about 18 million cases a year, with the deaths topping around 9.6 million a year. So it's big. You can put in perspective COVID-19, which has been around from March last year, and I think to date we have about 3.3 million deaths. Every death is very unfortunate. We've lost close members, but just in perspective, we can see that cancer is a bigger problem when it comes to mortality compared to COVID-19. If you look at the risk of death or the chance of death, is that 1 in 6 deaths currently is being attributable to cancer. And the leading causes of cancer worldwide being trachea, bronchus, lung cancer, and they're trending at around number 6 as the leading cause of death currently in the world. If you break it down, looking at high-income countries, middle-income, and low-income countries, we find that in the high-income countries, cancer is ahead of cardiovascular diseases, is accounting for probably close to half of total deaths in those particular countries. Of course, every country is a bit different. If you come to middle-income country like where Kenya we are at the moment, probably cardiovascular diseases and infections have a larger role. This was a paper published in the Lancet. We have our own homegrown statistics, which show that when it comes to cancer trends in Kenya, that 1 in 7 Kenyans are likely to die of cancer before their 75th birthday. Cancer is killing about 3 to 4 times the people who die from road traffic accidents. And already road traffic accidents is it's a huge problem in our country. It's estimated we are losing over 30,000 people per year again to cancer. And if you look at the various causes of death, cancer is ranking number 3 amongst leading causes of cancer, secondary only to pneumonia and malaria. In terms of diagnosis, at the moment, it's said that 1 in 5 Kenyans is likely to develop cancer before 75. That means of the ones listening in, if we are lucky to live up to 75 years, 1 in 5 of us will get a diagnosis that you have cancer. And of course, there are other things that pertain to low-income countries. The diagnosis is always late, and so forth. If if you look at world data, if you stratify these deaths in cancer, you know, in which particular age groups is it occurring? Majorly occurring in the over 70 years. So 70 years are really having it rough when they get cancer. The mortality is at a very high level compared to all other years. If you look going all ages, you know, age standardized is probably almost a tenth of what we are seeing in the 70-year-olds. Looking at, you know, the statistics of deaths and what we've been able to change over the years from 1990 to 2017, we see that cancer deaths have increased, but that in itself doesn't say anything, because also the population in the same time has also increased significantly. What is important to look at is the age standardized cancer death rate, the one which appears blue line at the bottom. Well, basically, it shows that from 1990 to 2017, we've had some improvement in reducing cancer mortality by around 15%. So it's not much, but it's still some improvement, implying that we still have a long way to go to dent that figure. So overall, looking what are the available tumor therapeutic modes at the moment, we have several modalities, and even with all this, you can see it's still a challenge to get that number down. So we have surgery, radiation therapy, gene therapy, targeted therapy, immune therapy, and the likes. So for us who are in the specialty of anesthesia, probably meet these patients mostly when they are coming for the operations. We'll also meet them in case they have to go for critical care admissions, and also for controlling or managing their pain, which is brought about by cancer. So overall, when you look at cancer surgery globally, we're talking about 80% of patients who have solid tumors will require surgery, be it for primary cure or debulking. With the explosion of numbers of cancer world burden, not just for the disease, but also the requirements for surgery. So going back to basic level, how do we know, what's the progression from normal to actually where to get a tumor, and then all the way to macro-metastasis. So generally we have normal cells, which for some reason, be it genomic instability, something genetic, sometimes it's a viral infection, sometimes it's an environmental factor that causes the genetics of these normal cells to change and to become dysplastic. Get additional blood supply, and then becomes what is called now a carcinoma in situ, and invades the local tissues to cause disease. This carcinoma in situ may undergo what is called epithelial mesenchymal transition. This basically is a transformation that allows the tumor cells to be able to extravasate and enter the bloodstream, be it blood vessels or lymphatics, and through that is able to move to distant tissues. What happens in the vascular system is that ideally our immune system should be able to detect these cancer cells that have entered the vascular system and be able to destroy them. But for some reason, in certain conditions, these cells escape immune detection, and they're able to move to distant tissues through the circulation. We know the common tissues, in this case, bone, lung, brain, and liver, etc. What happens in these target tissues, the tumor cells, the circulating tumor cells are able to adhere through the adhesion molecules. They get extravasated, enter the tissues, and now become a micro-metastasis. Once that has happened, again through releasing of certain chemokines and certain factors, it's able to colonize the tissue, it's able to flourish, proliferate, and again, as it becomes larger, it requires nutrients, and we know that tumors, metastatic cells are experts at getting new vessels angiogenesis, and therefore now becomes a macrometastasis, and with all its ugliness. There's a special mention for natural killer cells. These cytotoxic innate lymphocytes, they play a huge role in cancer immunity, or keeping humans safe from cancer, because we know that our cells are constantly having getting dysplastic. There's always dysplastic cells being created, but NK cells, amongst a host of other responses, is able to give us some protective anti-tumor immune response. How NK cells work is through they're able to detect and lyse transformed or stressed cells. So it comes to surgery for cancer. It's a mainstay for cure. We know that. It's also not only when it's not cure, but also control, where maybe cure is not on the table, control becomes significant. So even with these advantages for both primary and even metastatic tumors to save and extend life, it's been acknowledged that surgical insult in itself may precipitate or accelerate tumor recurrence. This is not anything new. I think the early documents to, the earliest was documented, I think, was early in 1907, where it was shown that patients who had cancer and they had some form of surgery done for some reason, or in some of them, for some reason, where they had accelerated disease progression compared to patients who did not get any surgery. So this is a known fact. It's not common, but it's known that once you get surgery, for some reason, it may precipitate or accelerate tumor recurrence. Looking at this paper by Samir and Tom on surgery for cancer, looking at how does metastasis come in after cancer surgery, there are a few things that were postulated or came out from this paper. Is that one, with the primary excision, or be it the primary foci or metastatic lesion, that in itself is able to disseminate tumor cells. Therefore, tumor cells are able to enter the vascular system. But that's just one point. The other one is that also surgery itself is able to increase pro-inflammatory cytokines, including prostaglandins and catecholamines. What these do is that they're able to influence inflammation and immunity, and how that does that, they're able to allow survival of these circulating tumor cells in circulation, and these cells are able to escape the immune. With the pro-inflammatory cytokines, they're able to enable the circulating tumor cells to survive in circulation, or increase the ability to survive and evade the immune system. Again, we see the role of other leukocytes, including neutrophils, through the neutrophil extracellular traps, the nets. They allow the cancer or the circulating tumor cell to be able to move out of the vessel. Basically gives them this cloak or this blanket where they're, for lack of a better description, so that the normal cells that surveil cancer are able to miss them and they flourish in the outside the blood vessel. Again, surgery in itself allows that in areas where you had micrometastatic disease, that all these cytokines that are released that enhance or reduce the immunity, or actually they cause immune suppression or decrease cytotoxicity. What that does, that you get new metastatic foci is able to grow and proliferate. So in a nutshell, if you look at what surgery does, that with the tumor excision, you get the circulating tumor cells liberated during the operation itself. They enter the bloodstream, carried through either the lymphatics or the blood vessels, and they lodge in distant tissues to grow to metastasis. For all this to happen, a few things actually are influenced by surgery. One is that we have immune cell activation, and this is through various chemokines. We find increased interleukin-6, increased COX-2, increased matrix metalloproteinase 2/9, and the rest. The whole at the end of this activation of this immune cells is that inflammatory cells allow these circulating tumor cells to have better motility, better ability to invade tissues, and better ability to infiltrate. So this is the and better ability to proliferate. Again, with surgery, we have tissue hypoxia. Tissue hypoxia leads to induction of the hypoxic inducible factor, in this case 1-alpha, and the vascular endothelial growth factor. This one leads to increased angiogenesis. We know that tumors, as we've seen earlier on, they require a good blood supply to ensure that it continues to proliferate and invade local tissues. Another effect that allows CTCs to be able to lodge and become metastatic is that surgery causes pain, and pain, or what is called the surgical stress response, it activates the hypothalamo-pituitary adrenal axis, leading to increased cortisol production, increased release of catecholamines. At the end of the day, these ones act on immune cells, reducing the activity of natural killer cells and upregulating T helper cells too, which move from strengthening the innate to more of the adaptive, which again has particular conditions that allow these circulating tumor cells to be able to grow at a distant site. So these are generally the mechanisms that involve what are called the protumorigenic properties of surgery. If you were to look at the surgical stress response, again, we have the local response, which again drives it and combines that with the systemic response that we talked of, the neuroendocrine or neurohumoral system. At the end of the day is that they tilt the balance and cause a state of immune suppression. So the surgical stress response eventually drops the immunity. And we know that with lowered immunity, the chance of cancer regrowth or recurrence or metastasis becomes much higher. Again, just look at that summary that sometimes even when margins are clear, we always have what is called minimum residual disease. It could be microscopic, could be at a level that normal lab or pathology tests are not able to pick. But we know that also that initial period of surgery where you have increased inflammation and decreased immune surveillance, it may provide very good conditions for this residual disease to be able to grow and become a foci of local recurrence. So is it all bad with the surgery? Not really. We know that also surgery for removal of the primary tumor has anti-metastatic effects on surgery. One of that is that it eliminates pro-metastatic and pro-angiogenic factors secreted by the primary tumor. Since now the primary tumor is removed, it eventually terminates shedding of primary tumor cells, which again go into circulation, as you've seen. It also terminates or leads to termination of tumor-induced immunosuppression. So what happens is that with surgery, you'd prefer, where you have this interplay of anti-metastatic effects and also pro-metastatic effects, is you prefer a scenario where it leans more heavily on the anti-metastatic side. And that potentially, or those knowing that gives us potential targets where we can target and possibly tilt the scale towards anti-metastatic effects of surgery. So brings us to the question of the day. Can short interventions or events during the critical perioperative period tilt the balance between these pro and anti-metastatic processes? So at the end of the day, are we moving towards more metastatic dormancy or regression, or moving towards metastatic progression? We as anesthesia, when it comes to the operation, we're there for maybe 8 hours, 10 hours. And it is interesting to think that maybe that short interaction, having seen the mechanisms of recurrence and metastasis, and we know that anesthetics generally do affect immunity, do affect the stress response. So it's interesting to think that maybe those 4-6 hours may actually have, may influence outcome, in as much as the cancer journey is usually a long one. So let's see what is there. So the questions that have been canvassed when it comes to ability of anesthetics or analgesics to influence cancer is, one, do these agents or techniques or analgesics have a direct effect on cancer cells? Do they modulate the various arms of immune response? Do they have anti-inflammatory effects? Can they affect angiogenesis? Because if the answer is yes on most or probably all of this, then it brings up the possibility that ultimately anesthetics or analgesics may modify oncologic outcomes, which of course would be a big deal considering we're talking 45 million surgeries a year in the next 8 years. So let's look at the evidence base of what has been done regarding anesthetics and cancer recurrence. Most of the studies we find are animal studies. We have a lot of laboratory studies, so a lot of in vitro studies. We do have also some clinical studies, and the nature of the clinical studies, most are observational studies. And all of them lean towards an association. They suggest an association between some of the drugs or activities with cancer cells. I'm sure someone is asking, but where the random control where the RCTs, because we know that is what is the holy grail when it comes to evidence-based medicine. So we can identify there are reasons why we do not have quality RCTs, or let me say that the journey of RCTs is already left the station. There are RCTs running at the moment, but it's been difficult to perform for various reasons. Is that number one, we always combine anesthetic agents. We rarely use a single agent, so it's difficult to be able to pinpoint or to be able to withhold one of the agents or a class of the agents sometimes so that we see the effect of the other one. So patients require to be anesthetized, and also they require analgesia at the same time. So that makes it quite difficult. Like, for example, giving an example of a patient undergoing general anesthesia. You're either having an inhalational technique or you're getting IV propofol. While those will suffice for hypnosis, they're not sufficient as an analgesic. So you probably have to add an opioid, an NSAID, a regional technique. So because of all this, it becomes really difficult to fashion quality RCTs that may answer a question on a particular cancer. The other thing is that also cancer is not a single disease, in the sense that breast cancer, ovarian cancer, they're two separate diseases. The biology is different, the clinical presentation is different, the clinical course is different. And even where we have the same, like for example, you can talk of lung cancer. The division is, I was looking the other day, they have small cell, non-small cell, and a non-small cell, you have large cell, you have, 3-4 other types, and all of them, they have different clinical costs. So all this creates a hurdle towards quality RCTs. So with that, it doesn't mean that the animal lab studies and observational studies have not given us something. I'll just give a summary of what so far we know from that. Is that when it comes to inhalational or the volatile agents, that it's been found generally that they may enhance metastasis. They're still trying to elucidate the molecular mechanisms they're not well understood. But so far, what they've been able to tell, in as much as they can't link how, is that inhalational or volatile agents may have a direct survival enhancing effect. They suppress immune cell function and tumor cell killing. Also, the volatiles have been able to be shown to upregulate hypoxia-inducible factors, which again confer cytoprotective effect, in the sense that cancer cells can create now newer vessels and be able to survive. They also have pro-inflammatory effects. So again, in as much as this has been elucidated, there is also conflicting evidence. Not all the papers have shown the same thing. Some have shown a beneficial effect of inhalational agents. So we still have conflicting evidence among the inhaled agents, and also amongst different cancer cell lines, where you find some agents were pro-metastatic in one cancer line, but not on another. So all this just creates the area that when it comes to volatile, we may have generally accept that they may enhance metastasis, but the evidence is not strong enough to fully move in that direction. So this was a paper by Kazumasa, which shows the influence of isoflurane and SIVO, is that they think it interferes with the conjugation of natural killer cells, and therefore we said natural killer cells are able to eliminate cancer cells through cytotoxicity, or so by interfering with the conjugation, they find that those cancer cells are able to survive compared to the control, which did not have any of the volatile agents. Propofol, our favorite IV agent, it's used in theater is usually for induction, but also increasingly using it to maintain the whole course of anesthetic, meaning that you do not have to use a volatile anesthetic to maintain hypnosis throughout the whole course of the surgery. Again, these lab studies have shown that propofol may have anti-tumor effects through a number of signaling pathways. It's not through one way. That one, it's able to possibly regulate key RNA pathways and, of course, protein synthesis. It's able to protect against perioperative immune suppression. It also has antioxidative effects and does not suppress NK cell activity. Again, newer papers are coming up showing that also propofol can enhance anti-tumor effect of chemotherapeutic drugs, meaning the patients who have had propofol anesthetic, possibly the chemo works probably better in those particular patients compared to the ones who did not get any propofol. And looking at this paper by Ichi, where they found that propofol not only just can affect in the animal, and even in the animal, in this case, a xenograft tumor, in a rat, was that it inhibits tumor growth and metastasis. When they looked at individual cancer cells, again in the lab, they found that markers of ability to metastasize also inhibited, proliferation was inhibited, those promotion of apoptosis and chemosensitivity of chemotherapeutic agents. And at the end of the day, all these are thought that they can improve survival of cancer patients and giving better outcomes. So all these in vitro studies, again, propofol, when they compared how does it compare in different cell lines, cancer cell lines, they found that it has anti-tumor effects on gastric cancer, non-small cell lung cancer, breast cancer, and a few others. Again, just to stress, these are in vitro studies. What of the other IV or intravenous agents? We don't use ketamine terpentan a lot, but also but there's literature to that effect that generally both of them are able to suppress natural killer cell activity, again being protumorigenic. They induce tumor metastasis, particularly for ketamine. Ketamine was found to upregulate levels of anti-apoptosis protein in certain cell lines, again increasing the ability of cells to invade and proliferate. Now, when you move from the bench, from the animal studies, what do we have from observational studies where they've had one side where what is called TIVA, total intravenous anesthesia, basically a propofol-based maintenance of anesthesia, compared to where anesthesia is maintained using the inhalational agents, the halothane, SIVOs, isofluranes of this world. So key thing is that these studies were mostly retrospective. They didn't have mostly retrospective studies. The results are generally mixed, showing some of the studies showing that there's a beneficial effect of TIVA, and a few of them showing that actually there's no difference between TIVA and inhalation agents when it comes to anti-tumor activity. There is a published meta-analysis in 2019, which looked at 6 papers. But the key thing is that the interpretation is difficult, of the results is limited, was difficult. One is that the extent of surgery was not uniform. Some minimally invasive, others open, and thereabouts. So it's difficult to interpret when even the extent of surgery is different. The types of cancers, the cancer lines were different. Patient characteristics were also very different, making interpretation of the results quite difficult. So for any determination of a cause-effect relationship, the causal relationship, we probably have to await the large prospective multi-center RCTs so that we can get a definite answer, like do we be, whenever we have cancer patients, is it TIVA or is it inhalation, or it doesn't matter. Regional anesthesia or analgesia, this is basically using local anesthetics to be able to achieve anesthesia, or analgesia where anesthesia is not possible. So from literature in other areas, we already know that there are several mechanisms that regional anesthetics are able to work. And if you extrapolate those mechanisms to the mechanisms of cancer recurrence, then you start to get an idea that could regional anesthesia reduce cancer recurrence through the mechanism that we already know. We know that regional anesthesia is able to reduce the stress response of surgery. We know that it gives superior pain control. It's able to block the sympathetic nervous system, so the role of catecholamines. Further to that, we're able to reduce usage of opioids, which are going to see that opioids may be considered to be protumorigenic. Again, with regional anesthesia, there's certain times you may omit volatile agents. And again, the local anesthetic used has been found to have a direct effect on certain cell lines. So all these come together to bring the idea that regional anesthesia seems such a promising technique to be able to combat tumor recurrence. However, in as much as we know all this, is that we do not have any high quality evidence regarding local recurrence or tumor recurrence. As I said, most of the papers have been observational studies, and we await a number of RCTs which are ongoing. So this basically just shows that the pathways through which regional anesthesia and local anesthetics are able to either inhibit or block. So they're able to block the surgical stress response, inflammation, and pain. And eventually, we think that with that, we are able to reduce disease recurrence, progression of residual local disease, and also metastatic spread. What of the opioids, the workhorse of anesthesia? So opioids are quite powerful in terms of analgesic effect. But the key thing is that in terms of mechanism in our bodies, they have such varied effect. We have mu receptors on so many different tissues, including the cancer cells. And because of that, we have varied biological effect. We know that opioids reduce pain through the mu receptor in certain tissues. They reduce pain. And we know that with reduction of pain, then we have a reduction in the surgical stress response. But not only that pathway, opioids also do interact directly with the hypothalamus-pituitary adrenal axis, and they are able to enhance it. So while pain reduces secretions from the HPA axis, opioids directly found to enhance the HPA axis, eventually leading to the conditions that we think are able to allow for good conditions for cancer progression. Another effect of opioids is that it does inhibit natural killer cells, T cells, and myeloid tissue. So what it does, that reduces immunity. Again, with reduction of immunity, we do have a tendency towards cancer progression. And again, it's able to fuel angiogenesis. So when you have these conflicting variable effects of opioids, you're left wondering what is the net effect on cancer progression. So that's what we mean that opioids have variable effects. Another thing that from the studies that has been shown is that, yes, we have all these medications that are opioids, fentanyl, morphine, oxycodone, and the likes, is that they also do have conflicting evidence. You find that in certain studies, even dosage, fentanyl, low dose, high dose, may have an effect on some of these, and again, different opioids. So all these just make it a bit more difficult to interpret what is going on with opioids and cancer recurrence. But the prevailing trend is that periop opioid use is associated with a negative oncologic outcome. Lidocaine, which was mentioned as briefly mentioned within local regional anesthesia. We know that cells that are able to take in local anesthetic, in the cell, local anesthetic is able to interfere with certain cell signaling pathways, eventually leading to reduced cell migration and invasion. Again, it's also to reduce, able to reduce angiogenesis, because eventually it leads to reduced secretion of VEFG, which is an angiogenic factor. So you can see that, but again, this just remains within the realms of lab studies and animal studies. Coming to the NSAID, non-steroidal anti-inflammatory drugs, as earlier pointed out, cancer surgery really leads to increased, secretion of all these inflammatory mediators, or what you call the inflammatory soup. So that is an opportunity to see if there's medication that may influence inflammation. Probably it may influence cancer progression. So so far the studies have shown that NSAIDs act through two main pathways. One through the so-known, the very known cyclooxygenase pathway, the COX-dependent pathway. And through the COX-dependent pathway of COX-1 and COX-2, we know that eventually it reduces the ability of cancer circulating tumor cells to escape reduces the ability to escape the immune system, reduces angiogenesis, reduces metastasis. Through the COX-independent pathway, again, it's been shown that it reduces ability for the cells to proliferate, also increases ability of apoptosis and ability to repair DNA, which is a precursor for dysplasia. Alpha-2 adrenoceptor agonists, again, common in use now. We have dexmedetomidine and clonidine in clinical use in our hospitals. So again, not well studied in terms of clinical outcomes. We don't have many papers on the clinical sphere, but generally catecholamines are protumorigenic. So what has been found in animal studies is that these alpha-2 adrenoceptor agonists have pro-tumoral effects, and they are also suppress the innate immune system cells. These are the natural killer cells. So on one arm, they've been shown to be pro-tumoral, to have pro-tumoral effects. But we also know when we use dexmedetomidine for sedation, for this cancer surgery, it allows us actually to reduce use of opioids, which we've said opioids are possibly pro-tumorigenic. It allows us to reduce usage of volatile anesthetics, again, which we said do have a metastatic potential. So where is the balance? So that's what I guess we need further studies to be able to pinpoint for us in the clinical setup what happens, which predominates, is it the pro-tumoral effects or the anti-metastatic effects? Well, there are a number of other agents used in anesthesia. It's just that in the interest of time, we may not have time to go through all of them, but there are new papers coming up on the role of oxygen, dexamethasone, beta blockers, blood transfusion, hypothermia, in how they affect not only just local recurrence, but also metastatic potential. So, but again, still having the same limits that we don't have high quality RCTs, and the role is slightly unclear as we only have animal and lab studies. And again, which also those studies show a mixed picture. So in summary, when we ask the question, do those 4, 6, 8 hours we spend with the patient sufficient to be able to give us something on preventing cancer progression or recurrence? Is that yes, this evidence is there, it's only that it's not high quality. It's from lab studies and a few observational studies. And we've seen that the areas that mostly anesthetics are able to affect is the immune surveillance effects, inflammation, angiogenesis, again, which are the very key towards leading to cancer progression. So these studies, what they've given us is a signal. They've suggested a signal that certain anesthetics or analgesic agents may be beneficial on that point of cancer recurrence, while others may be detrimental. So still, and having this signal, you ask yourself, what does it mean for me who is tomorrow going to handle a patient in theater who's coming for cancer resection? So what we know so far is that we have insufficient evidence to suggest a change in anesthetic practice or to use specific agents for the purpose of reducing. It's just because in as much as we have these lab studies, animal studies, they are not RCTs. And remember, again, even these studies have given us mixed picture. So far at the moment, we don't have conclusive evidence to suggest that a particular agent may do this or that. So for now, we continue as we've been, as we eagerly await RCTs which are ongoing. And the other thing is that even when we get these signals from particular papers, that cancer is quite heterogeneous in terms of its biological and clinical behavior. So you find one type of breast cancer is not like another one. One may be sensitive to estrogen, another one. So it's difficult to extrapolate what you find in one paper to the next cancer. So the other thing is that with this huge burden of cancer in the world, looking at the fact that there's so many things coming up, be it on the anesthesia front, be it medical management of cancer, all this puts a case for a specialty called oncoanesthesia. We've seen certain hospitals in the world are able to get magnificent results from cancer surgery, and they're putting together what is called a program for oncoanesthesia. This is something I pray and hope that in this coming few months or years, it's something we'll have in Kenya. As you've seen, even in Kenya, cancer is a big issue. So the road is long, still don't have conclusive answers, but we have already an understanding of mechanisms. We understand what our drugs are able to do, and we eagerly await the RCTs that are being done so that ultimately we can benefit our patients. Thank you.
Thank you, Dr. Ngugi, for the wonderful and informative presentation. It was very informative and direct to the point. So at this point, in case you have any questions, I request you to use the chat box to channel them through there, then we'll respond to the questions. Just as an announcement, the webinar is recorded and will be available in the KSA website. So to allow Lee to at least take some sip of water, I want to invite our partner today, Patricia Nabire from Novartis. She'll make a brief presentation, and then after that, we can then go to the Q&A session. Patricia, karibu.
Thank you so much, Dr. Rachel. Just let me know once you can see my screen.
Yes, we can see your screen. Patricia, you can go ahead.
Okay, thank you so much, Dr. Rachel, and thank you so much, Dr. Lee, for your powerful presentation, especially discussing the impact on anesthesia on cancer patients. So once again, my name is Patricia Nabire, medical representative from Novartis, and today I'll just be taking you through pain management before, during, and after surgery using Novartis products. Just a minute, please. Okay, so for my agenda for the day will be pretty short. I'll just be discussing about what Novartis is offering in the space of pain management. I'll also look at the benefits of using Voltaren, injection and suppositories, and this will be my key focus for the day. And we'll also just look on the dosaging of some of the products that we are going to talk about today. So I believe one of the roles of you, the anesthetist, mostly is, it includes pain management for your patients, either before surgery, during surgery, and even after surgery. Yeah, and pain still remains a major concern for all patients visiting either the outpatient facilities and even inpatient facilities. And I believe it's imperative for all of us as the healthcare providers to be able to optimize pain management in order to maximize the benefits of treatment to both the patients and even to you, the healthcare providers. Just looking at what Novartis is offering, we offer you a huge basket when it comes to pain management. So from Novartis, we are the house of Therapy, and we have we are the originators of all the diclofenac salts in the market. So just looking at this particular slide, we have the diclofenac potassium salts, and here we have the salts that for both your adult patients and even for your pediatric. So we have the Cataflam tablets and even the Volfast. These fall under the Cataflam, under the diclofenac potassium salts. So for patients, probably just looking at your patient journey, for patients probably who now after theater, you can, in the wards, can be put on the Cataflam 50 milligram and even have the Cataflam 25 milligram for that covers the teenage population, as well as the Cataflam suspension that's for pediatrics. We also have a special formulation by the name Volfast. Volfast, looking at this particular molecule, it's also a diclofenac potassium, mostly for acute pain. And with this, we are looking at it's in powder form, and it's buffered by sodium bicarbonate, therefore allowing faster absorption into the system. And it has a 5-minute onset of action. So we are looking at probably a patient or a mother who's post surgery after CS, and in the wards they have a wound, and they still need to breastfeed their kids, and they need something that's going to relieve their pain very fast. So some of these patients are candidate. A mother like that is a candidate for Volfast to be able to enable the lady just be able to minimize the pain and continue even breastfeeding the child pain-free. Looking at the diclofenac sodium salts, we have the Voltaren range. And as I said, I'm going to put a special focus on the Voltaren injection and the suppositories. But we also have the Voltaren tablets, which is the 75 milligram, as well as the 100 milligram tablets. We also have an improvement of the Voltaren 75, which comes by the name Flotac. So Flotac is diclofenac combined with cholestyramine. And the benefit that this particular product offers to your patient is a better GI just protection, better GI protection. And just looking at it, we are also offering you a quality paracetamol IV from Novartis that comes by the name Tumour. So just looking at this slide, we are offering you pretty much all the analgesics that you need for your patients. So both the NSAIDs and even paracetamol IV. So as I said, I'm going to put a special focus on the Voltaren injection. And with this, I'm just going to talk about the efficacy of Voltaren when it comes to pain management. And this is actually a study that compared the analgesic efficacy of diclofenac, and it was being compared to ketoprofen for 3 days after knee arthroplasty for patients. And actually in this particular study, 64 patients were being reviewed. 24 patients were put on the Voltaren injection, 24 were put on ketoprofen, while the 16 were put on placebo. And you can actually see, and most of these patients were actually followed up by oral diclofenac, 150 milligram per day, ketoprofen 300 milligram per day, and placebo in the wards for 3 days. And just looking at the conclusion for this particular study is, you can see the patients who are on Voltaren here, which is being represented by orange. From day 1 to day 3, the mean pain scores were actually lower compared to patients who are on ketoprofen, which is being represented by blue, as well as patients who are on placebo. So it just proves that Voltaren is very effective when it comes to postoperative pain relief. This second study compares the efficacy of Voltaren with ketorolac. in reducing postoperative morphine use after major orthopedic surgery. And the design for this study, it was a double-blind, randomized, placebo-controlled, where 102 patients were being reviewed after undergoing knee replacement surgery with general anesthesia. And you can actually see that the mean 24-hour morphine requirements for patients who were on diclofenac here, being represented by the orange bar, was actually 36.3 milligram. For patients who are on ketorolac, actually required 47.2 milligram of the morphine, while placebo patients required 51.6 milligram of the morphine. So just looking at this, it just shows that preoperative administration of intravenous diclofenac significantly reduces morphine requirements. And we know that this is also an important goal in the current fight just to minimize opioid misuse and also potential addiction that comes with the use of opioids, right? Just looking at this type of patients also, I know when it comes to, when you're using mostly the general anesthesia, patients tend to, get a lot of nausea and vomiting. And also looking at some of the patients who are also restricted to nothing by mouth, we have the Voltaren suppositories for these patients. And the Voltaren suppositories, we have quite a number of formulations. So we have the Voltaren 100 milligram, which actually caters for your adult patients. We also have the Voltaren suppositories 50 milligram, the 25 milligram, and also the 12.5 milligram that also caters for the pediatrics. Yeah, so the recommended initial dose is mostly 100 to 150 milligram daily dose. In milder cases, as well as long-term therapy, 75 to 100 is usually sufficient. And I believe most of this, when you're dosing, it's mostly individually adjusted depending on the patient and also depending on the severity of the pain. So then how do we dose the Voltaren injection? So this one, actually, the injection is for adults only. So at least one or at the most 2 ampoules, either IM or IV. By giving IV, of course, we have to do the necessary dilutions with either glucose, normal saline or glucose. And we say that the ampoules must not be given as an IV bolus. Yeah. And also the Voltaren solution for injection should not be given for more than 2 days. And if necessary, treatment can be continued with the other formulations that we've talked about that they have. Either you can go with the Cataflam for the Cataflam or the Voltfast for, which offers you a faster onset of action, or you can also go with the Voltaren tablets, which you have the 75 milligram and the 100 milligram, or ideally you can also go for with the suppositories. So I believe that is the end of my presentation, and I'll take any questions. And to all our Muslim brothers and sisters, Novartis wishes you happy Eid, yes, and remain blessed. Thank you so much. Over to you, Dr. Rachel.
Thank you so much, Patricia, for the presentation. Also want to thank you for always being there for us and supporting us as the society. We appreciate you and thank you once again. So we'll then go to our Q&A session. The first question is from Wycliffe. Wycliffe is asking, is the prometastasis of ketamine also related to its effects on increasing perfusion to most organs in the body compared to other IV anesthetic agents? Maybe Dr. Lee, you can take the question.
Thank you for that question. So what is known is that we have certain conditions that are predisposed to either tumor recurrence or metastasis, and blood flow necessarily is not one of them. We know clearly about inflammation, about the surgical stress response, and if you look at what is so far known about ketamine, mostly is about its effect on suppressing the natural killer cells. And that, of course, affects immunity, and also the fact that in certain tissues it's been shown to have an anti-apoptosis or anti-apoptosis effect, therefore allowing or having the potential that cancer cells can survive, where maybe if ketamine was not given, they would not have survived. All those studies so far are lab studies. They're not clinical studies, so they've not been tested in patient population yet.
Okay, thank you, Lee. There is another question concerning blood transfusion. What's your thought on the progression of cancers in respect to blood transfusion? That's by Ali Chandani.
Yeah, I think just in the interest of time, I should have also talked about blood transfusion. It's very interesting that for up to 20 years, I think now, it's been shown that in certain cancers, patients who get transfused end up having a poorer course in terms of local recurrence or metastasis. We've seen, and that is independent of the pre-op HB level, and bringing up something called transfusion-related immune modulation. So the issue is that we believe that transfusions set up a situation of low immunity or immune suppression for some time, therefore allowing possibly seeding of this metastatic tissue or the local tissue regrowing.
Thank you. Dr. Lang is also asking about, I hope the comparative study of diclofenac versus ketoprofen provided rescue analgesia for patients on the placebo arm. Maybe you can comment on that.
Was that a question to me?
I believe so.
Well, I didn't give the presentation on the NSAID, so maybe Patricia, I think this was channeled to you.
Thank you so much. I think looking at the study that we have, patients on the placebo arm were actually not put on any kind of rescue medication, since the study was just comparing diclofenac versus ketoprofen. So we are not sure, because it was a randomized study, we are not sure what the patients on the placebo arm were actually put on.
Thank you, Patricia. There's also a question from Dr. Morar. She would want you to comment on the widespread use of oral morphine for many cancer patients in the counties, considering it's a protumorigenic, has protumorigenic properties. What's your thought on the use of oral morphine?
Well, I just want maybe to clarify that in as much as we have all these lab studies, animal studies that show a direction that opioids may have an effect, that also means that we don't also neglect the other role that those particular medications have. Like, for example, opioid is important for pain management. Pain is a central big issue in patients with cancer. Therefore, we have to provide pain management. And then the fact that we don't have conclusive RCTs yet to, definitely say these opioids are bad, local anesthetics are good, TIVA is good, gases are bad. No. At the moment, we are having kind of a hypothesis that has been somewhat tested in animals, in early lab work, in vitro work, and observation studies, but not a definite answer from RCTs. So I would say, please do not stop using morphine, since probably it's all that you have, because even that quality of life is important in terms of pain control.
Thank you for that. I think we can take the final question, which says, being that there are no studies that are strong enough to allow protocols, what are some of the do's and don'ts that in anesthesia for oncology surgery?
Well, my take would be maybe to be part of the population that participates to try and answer all these questions, in the sense that if there are people collaborating to do some of these studies, probably just hope on that. Number two, be on the lookout for what is new. We know always bench studies don't always translate to clinical outcome. So for now, do the best you can with what we have. And once there's new evidence, then we can change. So just do the best right now with the existing guidelines.
Okay. Thank you so much, Dr. Lee, for your contribution and for your participation in this CME. Just to inform you that this CME, you guys CPD accredited, so the tokens will be sent to your emails. That is for the doctors. For the nurses and the CEOs, you'll have certificates that will also be sent through your emails from the office. At this point, I would like to invite Dr. Nabulindo to give an announcement concerning the conference that is upcoming. Dr. Nabulindo, karibu.
Yes, thank you very much, Rachel, and thank you, Dr. Lee. On behalf of the Executive Committee of the Kenya Society of Anaesthesiologists, I would like to thank all of you for the continued patronage of our educational activities. We appreciate because the attendance has been quite impressive since we started last year. Now I would like to bring to your attention the KSA Annual Scientific Conference that is supposed to happen in August this year. The same dates we usually have our conference, August 18th to 20th, 2021. This is the 28th KSA and the 8th CCSK conference. Important to note is that the conference is going to be fully virtual, meaning that you will be able to attend the conference from where you are. All you require is your device and good internet. With this, we believe that the constraints of traveling and time out of work will not be in our way to be able to attend this very important activity. And we expect that you will be able to attend, as many as you will be able to attend as possible. So look out for information about how to register for the conference in the next few days. And we hope to congregate and share the information far and wide, even with your friends and colleagues in the international arena. So the information on how to register will be out in the next few days. Thank you. Thank you, Rachel. I think you can take the meeting back.
Okay. Thank you, Dr. Nabulindo. So at this point, I'd like to appreciate everyone who made time to attend this webinar. Thank you so much. Thank you to our presenters, Dr. Ngugi, and also to Patricia for your continued support to the association. And yeah, thank you. And I guess the webinar is over, so have a good evening, all of you.